patient arrives in the emergency department of Sant'Andrea Hospital in an ambulance.
In the management of acute heart failure, time to vasodilators treatment seems to be crucial in the attempt to improving patients' outcome. In this movie, we are showing how our group in Sant'Andrea Hospital University La Sapienza in Rome was trained in enrolling patients in the TRUE-HF study, a multicentric international trial aimed to evaluate the efficacy of urodilatin in the treatment of acute heart failure patients.
The patient complains of shortness of breath. The patient is triaged by a nurse that performs vital parameters. Body temperature is 36.5 degrees. The nurse inserts the symptoms in a computerized system, and she gets the yellow code that means immediately see the doctor. The patient is transferred to the emergency room for the care of the case. The medical doctor interviews the patient. The patient is immediately treated with oxygen and he is monitored. The medical doctor detects blood pressure and oxygen saturation. The blood samples are collected for the in-hospital lab test evaluation, both for clinical practice and for the future screening phase of protocol. An EKG is performed. Systolic blood pressure is recorded, showing the value greater than 110 millimeters of mercury. A point-of-care chest ultrasound is performed. The medical doctor checks if the EKG is normal. An initial physical exam is performed in a supine and orthostatic position, 30 to 45 degrees. And now there begins the 12-hour time point for the enrollment. Cardiac activity is normal. The medical doctor checks the presence of jugular distension. At the pulmonary exam, the medical doctor detects the presence of rales. No evidence of peripheral edema is detected. The respiratory rate is high. According to the anamnesis and physical exam, the doctor makes a diagnosis of the acute heart failure patient, and the physician administers 40 milligrams of intravenous furosemide. BMP is performed by a point-of-care triage meter on the whole blood. A high value of BMP greater than 500 is confirmed. The patient is sent to perform X-ray. The medical doctor sees the chest X-ray that confirms the presence of lung congestion. The medical doctor checks the laboratory exams. The medical doctor checks the inclusion criteria, including clearance of creatinine. The medical doctor proposes and explains the study to the patient. The patient agrees to the protocol and affixes his name, the date and his signature on the consent form. The medical doctor signs the consent form. The medical doctor gives the patient a copy of the consent form together with the letter for his medical doctor and together with the label that the patient will carry with him always. 2 hours after the administration of furosemide, the patient is still dyspnoic at rest and in 30 to 45 grade position, and he has not received 4 bolus of diuretic. After the recheck of inclusion and exclusion criteria, the medical doctor inserts the patient's data in the IVRS system in order to screen and to randomize the patient and to obtain the assignment of the drug. The medical doctor opens the laboratory kit of protocol for NT-proBNP and biomarker. The source document is filled in. Vital parameters, including respiratory rate and temperature, weight and height, are recorded. A blood sample for NT-proBNP, biomarkers and local laboratory for short routine lab test is taken. Systolic blood pressure is always greater than 110 millimeters of mercury. An EKG screening with the code of the study and the patient's ID is performed. All procedures will be performed 15 minutes before the administration of the drug. The drug is preserved at an adequate temperature according to protocol. The drug is withdrawn from the fridge. The medical doctor takes 2 packs of drugs according to the assignment of the IVRS, and the 2 packs will be administered at time 0 for the first and at 24 hours for the second. One of the 2 packs is opened. From a 250 cc's physiological solution, 5 cc are withdrawn by a sterile syringe. The 5 cc are inserted into a bottle of powdered drug. The bottle is gently agitated. The drug is aspirated from the bottle with the syringe. The drug is inserted in physiological solution. This procedure will be repeated even up to 24 hours for the second infusion. The infusion rate is calculated according to the body weight table of protocol. One minute before the administration of the drug, vital parameters including respiratory rate and temperature are performed. The medical doctor starts with an infusion of drug in the pump and she assesses the rate of infusion according to protocol. The therapeutic plan for the next 6 hours is completed. The blood samples are centrifuged to 4,000 cycles for 15 minutes. Plasma and serum for biomarkers are transferred respectively in green and blue capped tubes, and NT plasma in an orange tube. On the tubes will be inserted the ID of the patient. Biomarkers and NT will be collected in 2 bags, including a form with the data of the patient and the date and hour of withdrawal. The bag of biomarkers will be frozen. This operation will be repeated at 48 and 72 hours. The bag with NT-proBNP will be sent in room temperature in a box with the protection of polystyrol. The bag will be wrapped in a casing of cold gel and still wrapped in a protection. The pack will be inserted in the box. The box will be closed. On the box, there will be applied a label for the shipment by DHL that will be contacted by phone. All these procedures on NT-proBNP will be done at baseline and 48 hours. A label for EKG with data of patient and date and hour will be filled and affixed on the EKG. This procedure will be repeated at 24 hours, at 48 hours, and at 72 hours. The medical doctor, using a password, will enter into the information system for the electronic case report. The patient's data will be inserted. In the meantime, the patient is transferred from emergency room to ICU. The patient is evaluated for dyspnea according to a 7-point scale global assessment and signs the evaluation. All vital parameters, including temperature and respiratory rate, will be performed and reported in a source document, as well as adverse events and therapeutic variations from time 0 to 6 hours. The assessment with just vital parameters will be repeated at 60 hours. The medical doctor performs an echocardiogram in order to complete the clinical evaluation of the patient. The patient undergoes an EKG. The patient is evaluated for dyspnea according to a 7-point scale global assessment and signs the evaluation. The first drug administration is terminated. The medical doctor performs a drug accountability that will be reported in a source document as to adverse events and therapeutic variations from the time of 6 to 24. All vital parameters, including temperature and respiratory rate, will be performed and reported in the source document. The medical doctor starts with the second drug infusion. "28 hours after drug infusion, the patient contacts the physician and refers to sweating and asthenia. The physician checks the systolic blood pressure that is under 90 millimeters of mercury with the symptoms. 5 minutes before, the patient has taken an oral antihypertensive drug. The medical doctor interrupts the oral therapy and she waits 30 minutes more. After 30 minutes, the patient is still symptomatic and with systolic hypertension under 90 millimeters of mercury. According to the protocol, the rate of infusion is reduced by 50%. After 30 minutes, the situation is unvaried and the drug is temporarily discontinued according to protocol. In order to restart the study drug treatment, Systolic blood pressure should be greater than 110 millimeters of mercury after an experimental withdrawal. If the blood pressure is still below 110, the physician will decide to definitively interrupt the drug. EKG is performed. Blood samples for biomarker, NT-proBNP, and local laboratory are performed. The medical doctor does a drug accountability of the drug previously interrupted. The drug accountability will be reported in source documents as well as adverse events and therapeutic variations from the time of 24 to 48 hours. The patient is evaluated for dyspnea according to a 7-point scale global assessment and signs the evaluation. All vital parameters, including temperature and respiratory rate, will be performed and reported in the source document. The patient contacts the physician referring to dyspnea. After a physical exam, the physician thinks that the heart failure is worsening. And administrates 40 milligrams of furosemide. The physician decides to have the patient undergo a chest X-ray. The physician records the worsening of heart failure and fills in the CEVA form according to protocol that will be sent by fax. The medical doctor checks the chest X-ray and looks for signs of lung congestion. All vital parameters, including temperature and respiratory rate, will be checked with physicians performing the physical exam. The source document is filled, including adverse events and therapeutic modification from 48 to 72 hours. Blood samples for biomarkers and local laboratory are performed. The patient undergoes an EKG. The physician gives the discharge letter to the patient with home therapy and gives an appointment at 30 days for an ambulatory follow-up visit. The patient is visited in ambulatory for follow-up at 30 days. The physician performs a physical exam. The source document is filled, including adverse events and therapeutic modification in the last 30 days. The patient is contacted by phone and the physician asks him if he has had adverse events, a worsening of dyspnea and variation in his home therapy. The follow-up visit will be recorded in a source document and in the information system. The next telephone call is scheduled for 90 and 180 days. True AHF will capture rehospitalization until 180 days after randomization and mortality for the entire duration of the trial. Patient retention is very important in True AHF and demanded by regulatory authorities to report on vital status of all subjects at the end of the trial.